I'm Dr. Fakir Ovedi, and this is hepatitis C virus in adults. Here's a quick introduction to Hep C. The hepatitis C virus was actually discovered in 1989. Prior to 1989, it was actually referred to as non-A, non-B hepatitis because at the time, hepatitis A and B were the only known hepatitis viruses. Hep C is the leading cause of chronic hepatitis, cirrhosis, and liver cancer, which is referred to as hepatocellular carcinoma. Hep C is the primary indication for liver transplantation, and about 60% of transmission occur by injection drug use. Other risk factors for transmission include blood transfusion prior to 1992, high lifetime number of sexual partners, dialysis, and vertical transmission from infected mothers. Now, let's take a look at the prevalence of Hep C worldwide in the US and in California.
So when you look at the worldwide picture, you can see that about 185 million people have Hep C. Now, these numbers are likely underestimated because it doesn't account for example, the homeless people and also individuals who are incarcerated. So if you compare to type 2 diabetes, for example, you can see that type 2 diabetes is more prevalent. And then the same pattern in the United States. So about 4.4 million people are infected with Hep C, whereas about almost 30 million people have type 2 diabetes. And of course, in California, about 600,000 people have Hep C compared to 120,000 people who have HIV. So, in practice, you're more likely to see someone with diabetes than you are to see HIV or Hep C, unless you work at the immunosuppression clinic or Hep C or HIV clinic. So 350,000 people globally die annually from liver disease caused by Hep C. So it's actually an important infection. Now let's take a look at the progression of Hep C. So once someone is exposed to the virus, it takes about 2 to 26 weeks for acute infection to occur. And most patients are asymptomatic, so it's really hard to figure out the numbers here because if someone doesn't have symptoms, it's hard to study to see how many people are actually getting infected. So once someone has acute infection, a lot of people can actually clear the virus, just based on the immune system. So immune system can naturally clear the virus in a lot of people. However, not everyone can clear it naturally. So about 66 to 82% of patients will actually go on to develop chronic infection. So by definition, if someone hasn't cleared it in 6 months, it's referred to as chronic infection now. And as you can see, there's a huge range between 66 to 82% because it's really hard to study this if people don't have symptoms. And then once someone has chronic infection, about 25% of individuals with chronic infection will progress to cirrhosis. And this is a very, very slow progress. So the infection will cause inflammation in the liver, and over a period of 25 to 30 years, about 25% will progress to cirrhosis. However, there are some risk factors that can accelerate this progression. So for example, if someone has organ transplant, because they have immunosuppression, if they get infected, they can progress from chronic infection to cirrhosis, for example, within 5 years. So that's a lot faster than 25 to 30 years. Other things that will accelerate progression from chronic infection to cirrhosis include co-infection with HIV or Hep B, because those infections will also damage the liver. Alcohol consumption. So again, that will cause extra inflammation in the liver, so it will progress. It will accelerate the progression to cirrhosis. And here are some other risk factors that accelerate. And then about 25% of patients who have cirrhosis will go on to develop hepatocellular carcinoma or decompensated liver disease, and eventually death without liver transplantation. So at this point, patient will require liver transplant because they have decompensated liver disease. So once somebody has acute infection, majority of patients will be asymptomatic. However, some individuals will have symptoms like malaise, jaundice, and influenza-like symptoms. And actually, people who have symptoms are more likely to clear the virus. So that's a sign that the immune system is actually clearing the virus. And it can be, of course, elevated aminotransferase levels like AST and ALT. Now, once somebody develops chronic hepatitis C, again, most individuals will be asymptomatic. And at this point, ALT levels fluctuate, so sometimes they're elevated, sometimes they're normal, so you can't really tell from the ALT. Some individuals will have insulin resistance and steatosis, and of course, as the disease progresses to cirrhosis, especially advanced cirrhosis, you're gonna see signs of decompensated cirrhosis like gastroesophageal varices, ascites, coagulopathy, hepatic encephalopathy, hepatocellular carcinoma, and eventually death. And of course, some of these symptoms will be extrahepatic, so outside of the liver. So for example, the kidneys can be affected as a result in some individuals. So you will see, for example, glomerulonephritis in some individuals. Now, when it comes to the actual measurement of liver fibrosis, measurement and assessment of liver fibrosis, historically, the liver biopsy was considered the gold standard for diagnosing cirrhosis. However, it is no longer routinely done. Now, back, when liver biopsy is actually done, the way that they actually assess, so they will actually take the tissue sample and they will do histology on it and they will score it. So there's the Metavier fibrosis score from F0 to F4, and this is, of course, from this is a progressive scale, so it goes from mild to more severe, with F4 being the actual cirrhosis. So F0 is almost absence of fibrosis, and it progresses from F1, F2, F3, and then F4 is cirrhosis. And this is with Metavier fibrosis score, which is common in the US. There's also the Ishak fibrosis score that goes, it's the same concept, but it goes from 0 to 6. And 6 being cirrhosis. Now this is an invasive procedure, so you will have to use a needle to go into the liver and take tissue out. So it's not very pleasant. Other things that we can do, especially for pharmacists, you can actually, there's an equation that you can use which will give you the probability or the likelihood of having advanced fibrosis or cirrhosis. So the fibrosis 4 or FIB4, here's the equation, and you do not have to memorize this equation, but basically you have age times AST divided by platelet times square root of ALT, and whatever number you get, if it's greater than 3.25, there's a 97% specificity for having cirrhosis. At the same time, if it's less than, whatever you calculate, if it's less than 1.45, it's unlikely that the patient has cirrhosis. So there's a 81% sensitivity with that. So this is a simple equation that's routinely used in the clinic. There's a more complex equation called FibroSure. So it uses 6 serum biomarkers. It's more accurate than FIB4, but it's more difficult to use. So I see most people use FIB4. And then of course, to be, because equations just give you probability, so you don't really know for sure. In order to know for sure, you either need to do liver biopsy, or more recently we have elastography, transient elastography. So fibroscan is what we use. Basically, this is not something pharmacists can use, but hepatologists will use in the hepatology clinic. With fibroscan, basically they use ultrasound and it's elastography. So they basically use ultrasound to um, have the waves towards the liver, and then it will reflect back, and then based on the elasticity of the tissue, they can measure the pressure, and it's correlated to certain um, stages of fibrosis. So as fibrosis progresses, the tissue becomes more stiff. So these ultrasounds, when they reflect back to the detector, the pressure will be different. So based on that, they can tell you exactly um, what stage of fibrosis the patient is in. Now there are of course some limitations with it, but this is what's more routinely used because it is less invasive. Basically all you do is you use a ultrasound gun to shoot ultrasound waves at the patient, so they don't really feel anything, so it's convenient. And once someone has cirrhosis, everything I said so far is to measure fibrosis and then eventually identify cirrhosis. But once somebody has cirrhosis, we need to classify cirrhosis. So once somebody has cirrhosis, we use the Child-Pugh classification. So you do not have to calculate the score on a patient, but you need to understand the class A, B, and C and what they mean. So based on this scoring system, so 5 to 6 would be Child-Pugh class A, and then 7 to 9 is class B, and then 10 to 15 is class C. What's important to know is that class A is considered compensated cirrhosis, whereas class B and C are decompensated cirrhosis. And C is more severe than B. So at class C cirrhosis, basically the patient needs to get liver transplant.
When it comes to screening for Hep C virus, the recommendation used to be that we needed to screen baby boomers. However, because of the opioid crisis that's going on right now, the guidelines have actually changed to recommend that all individuals aged 18 years or older be actually screened one time in their lifetime, as well as people who get pregnant. For every pregnancy, as part of routine prenatal care, patients should be screened for Hep C. Now, annually, people who inject drugs, as well as HIV positive men having sex with men who have unprotected sex, and MSM or men having sex with men who take HIV pre-exposure prophylaxis, they should be screened for Hep C annually. And of course, periodically, all persons with ongoing risk factor for Hep C, and these risk factors are listed for you on the right hand side. These recommendations from AASLD and IDSA are actually consistent with the 2020 recommendation from the United States Preventive Service Task Force, which recommended all adults aged 18 to 79 years should be screened for Hep C.
Now let's take a look at diagnosis of Hep C. So the least expensive method we have for diagnosis is to have ELISA test for Hep C antibody. So if somebody, if you get the Hep C antibody, and if it's non-reactive, you can actually rule out Hep C. And of course, that is within reason. So it takes time for antibodies to develop. So if somebody had risky behavior in the past couple of weeks, then that's not really a good method of ruling out Hep C. Now, if the antibodies are positive or reactive, then we actually do the more expensive test, which is the RNA PCR. So we actually check for the RNA, and if we do not detect it, it could be due to two reasons. One could be because that was a false positive with the antibody. So if you don't find the RNA, that means the antibody was a false positive, so they don't really have an infection. Or if somebody had infection in the past and either the body cleared it or the patient received treatment, the antibodies will be around, so it will test positive. But if you didn't find the actual RNA, that means they don't have an active infection right now. So, that means that, once somebody gets Hep C and they get treated, going forward, you should never get the antibody test again because it will always be positive. So once someone is treated and you're wondering if they have another infection, you should just use the RNA test. And of course, if the RNA test is positive, that means they have current Hep C infection and they should be connected or linked to care to receive treatment.
Now, when you get results back from a Hep C RNA assay, there are three different possibilities. One is that the assay may not detect an RNA, and that could either mean that there is no infection, so that's why it didn't detect it, but also it could be a limitation of the assay. So with current technology, if the viral levels are actually less than 10 to 12, so there might be some virus in circulation, but the assay may not be able to detect it. So that's referred to as the lower limit of detection, and that's with current technology about 10 to 12. And then you might be able to detect it and not be able to quantify it. So you might see the results say detected, Hep C RNA detected, but less than 25, or quantity unknown. That means that the assay detected the virus, it just couldn't tell you the concentration, what was the quantity in international unit per ml. Or if the viral load is large enough, it could say that it detected the RNA and it would actually give you a level. So it will quantify what that level was. And that's typically if it's more than 25 international units per ml, most assays with current technology are able to actually quantify.
So now let's take a look at some definitions. So here on the x-axis we're looking at time, and the y-axis we're looking at the viral level increasing in basically in logs. So every increment is a 1 log increase. So going from 1,000 to 10,000 is a 1 log increase. So let's say somebody has Hep C, so their viral level is at some levels, let's say 1 million. So somebody's viral level is 1 million. So at some point we would like to start treatment in this patient. So let's say the viral load is 1 million and we start treatment. And treatment for Hep C, unlike HIV, is not forever. So it's just for a duration because we can actually cure Hep C. So we can actually clear the virus out of the system. So after a while, we will end treatment. So this will be your duration of therapy. So whether it's 8 weeks of treatment or 12 weeks of treatment or 24 weeks of treatment, at some point it will be the end of treatment. So what we would like to see is, once you start treatment, you want the viral levels to drop. You want it to continue to drop while on treatment and become undetectable. So here's your level of detection. So during treatment, while the patient is taking drugs, you want it to become undetectable. And then at some point, you stop treatment because we do not need to treat forever. So what we would like to see after you stop treatment is for the viral level to remain undetectable as time goes on. And if the level continues to stay undetectable, we call this a response, or this person was a responder. So they responded to treatment. So the question is, how long, should we check to see if the levels remained undetectable, or how long should we check? So the gold standard is to wait 12 weeks after the end of treatment. So it turns out if just because we can't really detect 0, so at the end of treatment it might be, for example, 5. So it turns out 12 weeks is enough time. So if there's any virus left for it to become detectable again after you stop treatment. So by definition, we wait 12 weeks after the end of the treatment, and then we check the viral load. And if it's undetectable after 12 weeks, we call this a cure, or a sustained virologic response, or SVR12. So SVR12 means sustained virologic response 12 weeks after the end of treatment. So that's our primary endpoint. So in clinical trials, they actually look for SVR12. So, whatever new drug they bring to the market, once they stop treatment, they wait 12 weeks and then they get a viral load. If it's undetectable, they call it a cure, because it's extremely unlikely that beyond 12 weeks become detectable. Another thing that can happen once you start treatment is for the levels to become undetectable while the patient is on treatment, and then when you stop treatment, then the viral becomes detectable again, and that's typically happens before 12 weeks, and we call this a relapse. So at week 12, after the end of treatment, if you check and you actually get detectable viral load, we say that this patient had a relapse, so you need to treat them again. Another thing that can happen is that you can actually start treatment, and then while they're taking the treatment, the viral load goes down. For example, more than 2 log drop. So, this is more than 2 log drop, but it never became undetectable. In fact, once you stop treatment, it continues to go back up. And we call this partial response. So they didn't really respond because it never became undetectable. But we call it partial response because the treatment did cause a 2 log drop. And this is just to distinguish it from if you start a treatment and it went a little down, but never more than 2 log drop. And we will actually call that a null response. So they didn't really respond to the treatment. And these definitions are important. If you had treated someone previously and you wanted to treat them again, that kind of helps us decide what regimens to use based on whether they were null responders or partial responders to previous treatment. The first learning objective is describe the hepatitis C virus life cycle and the mechanism of action of direct acting antiviral agents. Now let's take a look at the virus itself. So the Hep C virus is actually an envelope positive sense single-stranded RNA. So you can see here that so there's an envelope outside of the virus, and then within the virus there's the single-stranded RNA, which is surrounded by a nucleocapsid. And I'll explain what positive sense means in a minute. So the virus primarily affects the hepatocyte or the liver cells. And what it does is that, it's a single-stranded RNA. It's ready to be translated. So positive sense means that it's ready to go find the ribosome and translate the genetic material into protein. So the final product, once it goes to the host cell, is a polyprotein. And this polyprotein actually includes 10 polypeptides. And these 10 polypeptides have important role in the life cycle of the Hep C virus. So these 10 polypeptides, 3 of them are referred to as structural proteins. So there are core proteins that make up the nucleocapsid. And also there are 2 envelope glycoproteins, E1 and E2. So you can see E1 and E2 are in the envelope that have, and they have a role in attachment to the hepatocyte. And the remaining 7 peptides are non-structural proteins. So NS stands for non-structural. And each of these have a role. Now, because the Hep C actually the replication lacks proofreading, there will be a lot of variation. So every time it replicates, there will be mutations, and these mutations add up over time, and it has led to different genotypes. So in generally speaking, we have 7 major genotypes, and within each genotype there's up to 30% variation. So up to 30% variation will still be within a genotype. And then each genotype can also have subtypes. So the subtypes will be denoted by letters A. So for example, genotype 1 can have genotype 1 subtype 1A, 1B, and so forth. So in the United States, genotype 1 actually constitutes 75% of the cases, and the remaining 25% are genotype 2 and 3. So the remaining, so genotype 4, 5, 6, and 7 are not very common. So I'm actually not going to talk about genotype 4, 5, 6, and 7. So this is in the United States. So if you get a patient with Hep C who's coming from outside of the US, you should suspect other genotypes, especially from Asia. Like in the Middle East, genotype 4 is common, and other genotypes are common in Russia and Central Asia. Let's take a look at the life cycle of Hep C. So I'm going to orient you to this picture. So we're basically looking at a single cell in the liver or a hepatocyte. So you can see the purple area is the nucleus, and then surrounding the nucleus is the endoplasmic reticulum. And this is of course a rough endoplasmic reticulum because there are ribosomes that are attached. And then in the green structures are the Golgi apparatus. And then you can see the surrounding hepatocytes. So let's take a look at the steps in the hep C life cycle. So step one is actually attachment to the hepatocyte. So one of the primary reasons that hep C affects hepatocyte is that it needs to be associated with lipid particles like LDLs and VLDLs. And that's actually where LDLs and VLDLs are generated in the liver. So that's why, because the virus needs to be associated with LDLs in order to attach to a cell, it primarily affects the hepatocytes. So once it gets attached and goes inside the cell, the viral RNA will be released into the host cell. And as I mentioned before, it's a positive sense RNA, meaning that it doesn't really need to do anything other than to find a ribosome and translate its genetic material into protein. And that's exactly what it does. So the hep C RNA will find a ribosome and will translate into a polyprotein, which includes 10 individual peptides in a single long polyprotein. So as I mentioned, each one of these polypeptides has a function. However, in order for them to do their function, they need to be processed. So these need to be cleaved into individual peptides. So the host proteases actually will process the first few peptides. The remaining peptides are actually processed by hep C's own proteases. So NS2 is a protease, and NS3 and 4A are proteases. So NS3 and 4A together will actually process the remaining peptides. And we actually target this with drugs. So we have a class of drugs referred to as NS3, NS4A protease inhibitors. So by blocking the enzymatic activity of NS3 and NS4A, the virus will not be able to process the remaining peptides. And because the remaining peptides have an important function for the life cycle of the hep C, that will interrupt the life cycle. Now, once those peptides are processed, they actually remain in the membrane of the endoplasmic reticulum, and they will be rearranged, and which is initiated what NS5A. So one of these is NS5A. So we'll rearrange them and form a membranous web inside the membrane of the endoplasmic reticulum. And this membranous web is important because inside of the membranous web is where the new RNA will be replicated. And we actually can target this with a class of drugs referred to as NS5A inhibitors. So because NS5A will arrange this membranous web, we can actually block it. So we have NS5A inhibitors. And once you have all these proteins inside the membranous web, the first thing that the virus does is that it actually makes a complementary replica of the RNA. So it will actually make a negative sense RNA. And then that negative sense RNA will serve as a template, and then the polymerase, which is NS5B. NS5B is the RNA polymerase that will make complementary replicas of the hep C RNA. So the end products are actually positive sense RNA. So the end result will be the actual genetic material for new viruses. And because NS5B is the RNA polymerase for the hep C, we actually targeted with a class of drugs referred to as NS5B polymerase inhibitors. Another thing that NS5A does, besides forming the membranous web, is that it actually has a role in virion assembly. So once all these new RNAs are produced, they need to be assembled into a new virus. So again, this happens in association with lipid particles like LDLs and VLDLs. So really, when we have NS5A inhibitors, it really has two mechanisms of action. So it will block virion assembly, and it will also block formation of membranous web. And of course, the final step is for this virion to go through the Golgi apparatus and through exocytosis be released out of the hepatocyte, and then the cycle continues. So then it can attach to the next hepatocyte and continue the replication. So that's how it replicates. Let's take a look at how it actually causes damage to the liver. So while all this replication is happening, which predominantly happens in the hepatocytes, a lot of inflammation will happen. So the immune system will actually, try to clear the virus. So there will be inflammation involved. So one of the things that the body does is try to basically kill the affected hepatocytes. And there are also a lot of cytokines. So the ongoing inflammation will cause damage to the liver. Now, one problem is because the virus mutates very quickly, the immune system is unable to completely clear it in a lot of individuals. So that's why the virus persists, and the immune system will not be able to clear it, but the ongoing inflammation will cause fibrosis to the hepatic tissue. And over time, this fibrosis of hepatic tissue will lead to cirrhosis. One reason that the Hep C virus can evade the immune system is because of the lack of proofreading. So it mutates so quickly that antibodies that are made by the body cannot really recognize it once it gets mutated. Now here are the 10 peptides that I mentioned are the end products of the Hep C virus.
We have NS5B inhibitors, so sofosbuvir and dasabuvir. Note that these drugs end with buvir, so B for NS5B, and these are basically polymerase inhibitors. We also have NS5A inhibitors. We have 5 drugs on the market. So ledipasvir, ombitasvir, elbasvir, velpatasvir, and pibrentasvir. Note that these end with asvir, so A for NS5A inhibitor. And lastly, we have NS3, NS4A protease inhibitor. We have paritaprevir, grazoprevir, voxilaprevir, galecaprevir, and these end with previr and P for protease inhibitor. Now, one thing you want to keep in mind is that in order to prevent emergence of resistance in Hep C virus, it's important to combine at least 2 different classes of drugs. So you want either 2 or 3 drugs from different classes. What you do not want is to combine 2 drugs from the same class, because if you have multiple agents from the same class, it's not really going to prevent emergence of resistance.